Hi, I'm Dr. Alan Reznik. I'm back again. This is really part two of a two-part series on the knee. First video, I talked about why your knee gets swollen, and I want to talk about what we do about it when we see a swollen knee. The initial assessment comes in, someone comes into the office, they come and greet me. I like to know the history of what happened. Again, as I said in the first video, the timing of the swelling means a lot. If it's insidious, insidious means just sneaks up on you. If it just sneaks up on you and you don't really have an injury, there's a whole bunch of things that may be causing that, including inflammatory disease, as we mentioned, Lyme disease, even calcium deposit diseases like gout or pseudogout can sometimes do that. And then there is swelling that's associated with an inflammatory disease like rheumatoid arthritis, psoriatic arthritis, and there are others as well. So we might look at the knee and we might want to look at the fluid in those settings. If there's a lot of fluid, I might drain the fluid on the spot. I may look at the color and the nature of the fluid, having a sense if it needs to be tested further. If it's perfectly clear fluid, there's very, very low likelihood it's any type of infection or even a bad inflammatory disease. If the fluid has some cloudiness to it and would indicate some white cells, very low cloudiness, maybe an inflammatory disease. Very high cloudiness, it could be things like gout or an infection. So I might send that fluid for laboratory testing. At the same time, we're going to examine your knee and see if there isn't evidence of that. I'll look for evidence of a ligament tear or meniscal tear. Obviously, if those type of tears are present, some of those can be treated non-operatively, and we have some easy treatments for some of them, including physical therapy, bracing, time, and anti-inflammatories. But if it becomes obvious that it's a surgical problem, the knee is going to remain unstable and continue to swell and block your activities of daily living, we may do an additional workup. Almost everyone I do an initial x-ray on, as well as a good physical exam, because those two pieces, along with your history, 98% of the time I kind of know what's going on with your knee. In a small percentage of the time, I'll say, okay, this is the type of thing we might consider surgery for. I may have a presumptive diagnosis, which we'll discuss, and we may have a reason to get an MRI. I think one of the mistakes people make is they skip the first three steps. The good history, the great physical exam, and a plain x-ray, and go right to an MRI. And they see all kinds of stuff on an MRI because MRIs are hypersensitive that have nothing to do with what's wrong with you. If I have a little degenerative meniscal tear, but I have Lyme arthritis, I can treat the meniscal tear. If I don't treat the Lyme disease, you're not going to get better. So I really have to pour out why and figure out what it is that's actually causing the swelling and treat that directly to solve your problem. Once again, this is Dr. Alan Reznik. Thank you for listening to part two of the knee series. I could be reached at our office through the phone number 203-865-6784. Thank you.